Hello everyone, good evening and welcome to the EUROGEN webinar programme. Just before we get started, I'd like to take a couple of minutes to explain a little bit about what EUROGEN is and does. EUROGEN is a network of now with 57 hospitals in 20 member states, and we're basically collaborating to share knowledge about patients with rare urogenital diseases and complex conditions. So some of our activities, well, one, we provide virtual consultations, so we can gather all the experts from our hospitals and provide expert advice on patients with rare diseases and complex conditions that fall within the scope of our network. So if you have a difficult case, please get in touch. This service is free and it's provided by the European reference networks. Also, I should say yesterday, we're funded by the European Commission and have been since 2017. And yesterday we had some really good news that the ERNs have been guaranteed funding until 2027. And they've been allocated 83.4 million euros in the EU for Health programme. So that's fantastic news. So it means that we can continue to do more of what we're doing. As well as the virtual consultations, we have training and education activities like this one, and we also have a clinical exchange programme where we can send any members of the MDT between our hospitals, again for training and knowledge sharing purposes. We also have a EUROGEN patient registry that we're developing, so this is very exciting. We hope that once the 57 hospitals are contributing all the data about the patients with rare urogenital diseases and complex conditions, this will provide a huge evidence base for research going forward. And then finally, we also collaborate on clinical practice guidelines. So without further ado, we thank very, very much Professor Marc Miserez, who's Professor of Surgery and Head of Clinic in the Department of Abdominal Surgery in the University Hospital of Leuven, Belgium, who's obviously a member of our network, and Pernilla Stenstrom, who is Associate Pediatric Surgeon at Skåne University Hospital in Lund in Sweden. So thank you both very, very much for sharing your expertise here with us this evening. And they're going to talk to us about a surgical guide for patients with anorectal malformations that don't do well. And this is part of a series on anorectal malformations that we're doing with EUROGEN, ERNICA, another ERN, and also the Anorectal Malformation Network. So Marc and Pernilla, thank you so much. You have the floor and we really look forward to hearing from you.
Thank you very much, Michelle. So welcome to this webinar about a surgical guide to patients with anorectal malformations that don't do well. And we have no, we declare to have no conflict of interest. Thank you, Marc. So first, when talking about not doing well in anorectal malformations, we need to consider that the treatment certainly includes several aspects of both physical and psychological functioning, such as urinary tract function, sexual function, concomitant malformations, psychosocial support, and/or support to establish coping strategies for situations or periods of not doing well. However, in spite of this multispectral need, in this webinar, we will mainly focus on bowel function. Next, please. So we would like to start giving a reflection about who could possibly decide on if a patient with anorectal malformation is not doing well, because this could have implications for how to start investigating the problem. Is it the legal guardians who raise the issue, or the child, her or him herself? Or is it you as the professional, or maybe your team, or is it the school that complains? And in a cultural setting, what could we possibly aim for? Next. Assessing a patient who is not doing well will benefit from working according to a clear structure. Start listening carefully to your patient and circle the main problem. Make your examination as standardized as possible, describing anatomy, symptoms according to a routine. And objectify as much as possible by using radiology and validated questionnaires. And this is in order to be able to discuss with your multidisciplinary team. Then a proper documentation of problems and your recommendations will bring transparency to patients and other professionals, which will help the patient in the end. And then keep close contact with the patient so to ensure compliance and possible improvements or problems. And in doubt, take help. Contact a high-volume expert center or use the platform for ERN, the CPMS, for any discussion. Next. We don't hear you, Mark.
Sorry, do you hear me now?
Yes.
Okay, sorry. So also hello from myself. Just as you heard from Pernilla a few moments ago, this multidisciplinary team is extremely important. And you see here some of the partners involved in this, really taking care of this patient during a very big part of his or her lifetime. And of course, you don't need all people at the same time around the patient, but I think you need to know where to find them, when to find them, and very importantly, the pediatric surgeon who took care of the baby when the patient was born is probably the one who will coordinate all surgical and medical activities, nursing activities over the decades to be followed. Just a small word, ladies and gentlemen, on normal bowel function. And we don't want to say too much on anatomy and physiology, but just as a starter, you all know that in the sacral and the lumbosacral region, defecation is controlled by autonomic defecation reflexes. But there's much more than that. We also need this voluntary control, which is controlled by the brain, to have this very, very delicate coordination between muscles, nerves, pelvic floor anatomy, and so on, in order to have normal bowel habits. And we believe it's important for you to stress that toilet training generally is achieved at 4 to 6 years of age. So at that time, we should be able to determine quite well if a patient will have voluntary bowel movements and will develop or not develop continence problems. We are surgeons, so we should be very much acquainted with pelvic floor anatomy. As you can see here, the anatomy of the external sphincter, the anatomy of the levators with the puborectal sling going to the pubic symphysis, the specific muscles of the perineal body, all taking important part in adequate defecation and bowel habits. Just one slide on the normal pelvic floor changes during defecation, as you all are all aware of. It all starts with rectal sensation, which will enforce the recto-anal inhibitory reflex. By that, some anal sensing in the canal will happen for liquids or for stools, and then if it's socially acceptable, we will release the puborectal sling and we will start defecating at that moment. In incontinence, many different parts can be involved, as you can see here on the slide, and as we will highlight later on during this webinar. Maybe one important point on positioning during defecation is this image of the Thinker of Auguste Rodin, and it clearly nicely shows this squatting position with the knees a bit elevated, a little bit bended forward, because in this position, ladies and gentlemen, the puborectal angle will flatten and will improve evacuation from the rectum through the anal canal.
To do well with regard to bowel function is generally defined as having voluntary bowel movements, fecal continence, and to be without constipation or outlet obstruction. So in assessment of patients who are not doing well, we need to consider the here surrounding predictive factors: the type of ERN, spinal and sacral malformations, age and cognitive status, sex, psychosocial support, and not at least the surgical success or complications of reconstruction. Next. So all these predictive factors influence patients' physical prerequisites. For example, anorectal reflex, the anorectal sensitivity, the capacity of the rectum, as well as the overall pelvic floor capacity. And not at least their gut propulsive forces and stool consistence largely play a role for a final good outcome. Next. But in clinical daily work, we need to simplify this complex predictive factor map. And for fecal continence, you could use this fecal continence score in clinic. It summarizes the severity of sacral and spinal malformation and types of ERN. And this could be an attractable and useful tool in clinic, published by King et al. Next.
So summarizing what Pernilla just said is, I think, nicely written in this sentence that we took from the paper from Victoria Lane, that a child with a good prognosis, based on the previous slide that you saw, and having an adequate repair, without any evidence of sacral or spinal abnormalities or dysraphism, having good morphological sphincters and an intact rectosigmoid with normal motility, such a patient, such a child should, at a certain time of potty training, become continent. And this is very important to remember, ladies and gentlemen, during the further course. Now, you all know that data from expert centers are not always reflected by real-world data. And this is why I just want to highlight this paper that Pernilla and I co-authored, coming from the ARMnet consortium, looking at outcome of patients with a so-called benign or good prognostic subtype, namely the rectovestibular fistula. And if you look into detail to the data of this paper, you can see that astonishingly 30% soil frequent or daily, and more than 11 or 12% have frequent or daily accidents. So this is real world data, and we should really indeed try to do better. Some things are in our hands, some things are not into our hands. And this is what we will highlight later on. Now, as Pernilla said, we will focus on bowel function. We will not focus on urinary or sexual function, because bowel function already is very extensive, and that's why we would like to highlight this tonight. Voluntary bowel movements is a very important one. Now, what does this exactly mean? Well, we propose you to go back to the paper by Holschneider that brought in Krickenbeck Castle in Germany many experts together more than 20 years ago. And voluntary bowel movements there was defined as feeling of urge, rectal urge, the capacity to verbalize this urge, and the capacity to hold a bowel movement if not socially adequate. Secondly, of course, we have to focus on constipation. We have to focus on incontinence. And as you all know, if a patient has incontinence signs, we need to distinguish between overflow incontinence due to constipation or true fecal incontinence. Let's also not forget to ask patients if they're currently on a bowel management program, if patients, for instance, are secondary transferred to your department. And if they have a current bowel management program, if they are clean or not clean under this management program. We said we would not discuss urinary symptoms, but of course, if a patient has signs of urinary incontinence or dribbling urine as signs of a neurogenic bladder, This is important to know because if a neurogenic bladder exists, your defecation habits might also be influenced by neurologic damage due to the same reason. Now the workup, we split up the workup in 10 slides, and the first one, of course, is a detailed history, as we have always done during our medical profession, of not only the patients but also the parents. Sometimes a bowel diary is useful because it objectifies the bowel habits during 2 or 1 week. And for instance, if you are more interested, you can go to the ERIC site of the Children's Bowel and Bladder Charity in the UK, where a nice downloadable bowel diary is available. It's logical that you want to look into all previous operation reports, that you want to check whether all previous screening investigations have been performed, and more in detail, one of the most important parts for us surgeons to distinguish is the anatomical, where we can deal with as surgeon, versus more functional contribution of the problem. And again, as Pernilla said, and highlighting here again, has the sacral and the spinal evaluation been performed thoroughly? Because this will influence the answer to this question, of course, largely. Validated questionnaires are very useful and more are important and necessary in evaluating stool habits of the patients. But the problem, as highlighted here by the group of Ernesto Leva, is that we have so many different questionnaires, some validated extensively, some less validated, available. Holschneider, Rintala, Peña, Krickenbeck, Kelly, Baylor, we can go on. But the problem is, as was highlighted in their paper also, is that these scores are often not comparable for most types of ERNs. And this is problematic, of course. And it was highlighted that there is really a need for a questionnaire that is universally accepted and that accurately assesses bowel function in this patient cohort we are dealing with. So this is maybe some work for ARMNet, for eUROGEN, or for collaborative initiatives later on. And more added to that, ladies and gentlemen, we're not talking only by symptoms, but also we're talking about quality of life. And often there is an overlap between both questionnaires. Again, time does not allow us to go into detail, but it's important to distinguish symptoms versus quality of life. Let's go on with the physical examination. It's logical we look at body weight, at the trophic state of the patient. We look at distension, fecal impaction, or scars on the abdomen. But the anal inspection, of course, is crucial. Where is the location of the anus? Is it open or is it completely closed? Are there some prolapse signs? Is there staining around the anus? Is there a flat bottom, as you can see here on the left, which is a prognostically bad sign, as you know? Is there an additional dimple apart from the anal opening? And very useful is the anocutaneous or the anal Winker reflex, as you can see here, because it demonstrates that if you touch the anocutaneous or the mucocutaneous region around the anal opening and you elicit a contraction just around, it is the external sphincter which is contracting due to this reflex. Further physical examination, the length of the perineal body to judge the positioning of the anus again by examining or calculating the so-called anal positioning index, as you can see here on the right. And of course, last but not least, an adequate digital examination rectally, if the patient allows, of course, to judge the anal canal diameter for strictures. And here is one of the possible calculations you can use to evaluate, is the caliber adequate for the weight or the age of my patient? To judge fecal impaction, to judge the resting tone of the internal sphincter, and by doing this rectal examination and asking the patient to squeeze or to strain, we can have an evaluation of the anorectal angle by relaxation or more tension of the puborectalis muscle. Technical investigations, they start, of course, with what we normally already have available. It's the abdominal or the pelvic ultrasound, for instance, for a presacral mass, for fecal impaction. And of course, a contrast enema is still very, very valuable to evaluate whether any resections were done previously before the patient was transferred to you. To judge any segmental or diffuse dilatation and especially in particular a megarectum, and to judge any strictures over the rectum or the proximal colon. And then it gets a bit more in detail, and we believe this is one of the most important imaging facilities that you can do. It's the MRI of the pelvis. I will not go into detail, but if you want, I think this table from the paper of Desai et al. Nicely summarizes what you all can see if you look together with your radiologist. This is very important. Here, for instance, you can see one image of a coronal imaging, where you can see that the rectum is crossing not centrally, but crossing the right levator and then entering within the puborectal and external sphincter again centrally. But you can see nicely see that here the rectum is not adequately centered in the middle of the body. And it allows also, ladies and gentlemen, if you can combine the pelvic imaging with spinal imaging, you can look at spinal cord anomalies, you can look at vertebral anomalies, and in addition, you can judge whether a presacral mass is present, whether there is any roof, a residual or a restant of an original fistula, and of course, whether there are any gynecological abnormalities. So all in a whole, MRI of the pelvis is a crucial investigation in our workup. Probably less important is anal endosonography. It's a bit difficult sometimes because we don't have probes for very small children. You could distinguish a muscle defect versus atrophy. You can do it in 2D or 3D, but the additional value versus the MRI is not clear, and that's why probably it's not universally available. We're coming to an end on number 8, the anorectal manometry. If you have an anorectal manometry lab, anorectal manometry can help you very, very much, as depicted in this systematic review very recently published, because you can look at the rectoanal inhibitory reflex, you can look at the high pressure zone, you can look at the anal resting pressure and the squeeze pressure. But most importantly, of course, an anorectal manometry is useful to depict anismus or dyssynergic defecation by a balloon expulsion test. What does it mean? A patient will increase the anorectal angle by increasing the contractility of the puborectal angle at times of defecation. So when we just would expect the contrary. And this is, of course, something you could try to counteract with physiotherapy and biofeedback. But again, as we said in the questionnaire, ladies and gentlemen, here again in manometry, we need standardized protocols because they limit currently a really comprehensive analysis of their utility in our specific ARM patient population. What about colonic motility? We already mentioned it, looking at the contrast enema. How could we judge whether there is a diffuse versus a more segmental colonic hypomotility? And of course, the diffuse hypomotility will be again a bad prognostic sign. Well, I advise you to go into detail by looking at this review of Esbran of the motility group. Most of you know the two most popular ones being radio-opaque markers on the left side and bowel scintigraphy on the right side. But as you can see, many new kits are coming on the block, also colonic manometry, but the place of it, and again, normative values and protocols are very, very unstandardized currently, and there is work to do to try to have normative data again in normal patients and in ARM patients. So for the time being, scintigraphy and radio-opaque markers are probably the most important ones. And of course, our workup, ladies and gentlemen, culminates in an examination under anesthesia, where of course, again, you have to include your colleagues like the gynecologist and the urologist. We, from our side, we will ask our anesthetist to try to avoid the use of muscle relaxation, to have a nice evaluation of the sphincter complex, but also to have a nice evaluation of the anal canal diameter, the rectal diameter. This is, I think, the most important part. It's an electrical stimulation of the muscle complex over the perineum to see whether the anus is nicely and centrally located within the muscle complex. You can judge more adequately the length of the perineal body, and if the patient has fecal impaction, you can end your examination under anesthesia with a thorough rectal lavage. This brings me to an end on the workup, and I give back the word to Pernilla.
So thank you very much, Mark. Now bridging over to symptoms. And here we will refer to the paper by Lane, published in 2020. So when assessing a patient who suffers from constipation, both functional and anatomic reasons need to be considered. So with regard to functional aspects, the spinal status again is essential, and also excluding a presacral mass could be needed. Then with regard to anatomic reasons for symptoms, constipation could be caused by stricture, either on skin level, in the anal canal, at the colostomy closer site, and all these could lead to megarectum, and then especially, of course, the rectal stricture. Next, please. Regarding fecal incontinence, mainly anatomic reasons to it will be focused from here on. And these are stricture, skin level or rectal stricture, rectal or mucosal prolapse, and anal mislocation. Next, please. So now we go over focusing only on potentially surgically correctable diagnosis for constipation or fecal incontinence, and that is stricture, prolapse, megarectum, and anal mislocation. And although surgery might be an option to these conditions, all evidence tells us that we need to support the patient with a thorough bowel management treatment program before selecting the right patients for surgery. Because if surgery can be avoided, it could be good, because it is connected to a lot of complications. And we also need to say that bowel management is very essential in making it better for patients who are not doing well, but it is a broad area, and we will specifically focus on this in a later webinar. Next, please.
So indeed, as Pernilla just said, if we see a problem which might be surgically amenable, we have to ask ourselves 4 questions. First of all, is the symptom surgically correctable? Secondly, what do we want to do about it? And that will follow in the next few slides. But thirdly, can we win time by just a wait and see for the moment? Because we know that many patients get better when they get older and when they get better trained. So ultimately, ladies and gentlemen, we have to ask ourselves for every potentially surgical correctable problem, is the potential benefit of our reduced surgery outweighing the surgical risks? And this is the first item that will be highlighted by Pernilla, which is the stricture.
So the anal skin level stricture is, according to literature, the most common long-term complication to anorectal reconstructions, being reported in 0 to 50% of cases. And these various frequencies could, of course, depend on different definitions of stricture, which is often defined as being on skin level, only skin level, beneath 3 millimeter depth, intractable to dilatations, giving rise to obstructive outlet symptoms. And it is a pity, but very objective definitions as regard to recommended Hega sizes, they are scarce to find in literature. Next, please. So if you find a skin stricture considered to cause outlet obstruction or symptoms not responding to dilatations, or the dilatations are painful, Heinrich-Mielke-like strictureplasty could be an option. In this procedure, the strictured anal opening is marked by 4 stitches incised in between them cross-sectionally and then closed longitudinally along the anal opening, so to enlarge the anal opening. Next, please. So, in one of the reports of Heineke-Mikulicz-like strictureplasty, reporting on 20 patients, bowel function improved in as much as 70% of patients, and about 50% could diminish their bowel management. And importantly, there was no worsening of stooling symptoms or incontinence reported. Next, please. However, compared to skin stricture, the rectal stricture is more severe, and it often raises more severe outlet symptoms and can even lead to megarectum if not carefully treated. So, reported documented risk factors for rectal stricture are laparoscopic surgery, not dissecting the anatomy properly in the anal canal, not respecting the anatomy around rectum, and if rectum becomes too stretched, this can lead to diminished blood perfusion, rising the rectal stricture. And real rectal stricture most oftenly do not respond perfectly to dilatations, but instead require redo pull-through. Next, please.
So now we move to the second item, which is surgically correctable, and that is rectal prolapse. Now, the first thing to say, ladies and gentlemen, is that the rectal prolapse we see in ERN patients is mostly fixed and only mucosal. So clearly different from the reducible full layer prolapse you see on the right in a non-ERN patient. And this will have an effect on the surgical options. Brisigelli and colleagues wrote or promoted a nice definition based on protrusion going from minimal over moderate to evident, and based on the circumference, hemicircumferential or circumferential. The incidence can differ very widely, going from 4 to 60%. And why is that? Because there are so many possible risk factors. And again, time does not allow us to go into detail, but this slide highlights the possible preoperative on the left, the possible intraoperative in the middle, and the possible postoperative risk factors that might provoke or increase the risk for rectal prolapse. The ones in dark black are the most important ones, but as a whole, and importantly for you to remember, is that many of these factors seem to be related to too much mobility of the rectum that was pulled through. So if we want to go for prevention, this is some important point that we should take into account and look into detail at those different items maybe after the webinar to see what you could do technically to try to avoid rectal prolapse in your next cases. So when to opt for surgery? Of course, when symptoms and affecting quality of life are there, you could consider treatment, surgical treatment, and I highlight some of them which can occur in about 25% of patients: bleeding or mucus discharge, a difficulty in sitting or pain, sometimes evaluating into a stenosis, and of course the most cumbersome is problems with continence due to interference with anal canal sensation. Do not forget that there is a small chance for symptoms or for the problem itself to resolve with time. If you go into surgery, we would like to start first with a multiple choice question that will be presented by Pernilla.
So this is exciting. If you look at this image, what would you recommend as treatment for this rectal prolapse, giving the patient symptoms? Would you go for resection, a redo pull-through, rectopexia, or no surgery, or maybe other?
Can we vote, Loes?
Yes, everyone can vote. We already have like 10 votes, so we take a few more seconds for everyone to make a choice.
Perfect.
Okay, I think everyone who wanted to vote has voted, and 64% said they would do a resection, 14% a redo pull-through, 9% rectopexia, and 14% no surgery at all.
Okay,
So
thank
that
you
was
very
interesting, Mark. What does literature say about this?
well. Thank you for the voting indeed. Well, first, one word on rectopexy, and I quote here what Risto Rintala and Mikko Pakarinen wrote already 8 years ago, that since most of these patients do not have a full thickness prolapse, which is very mobile, this problem is in the most circumstances not curable by a rectopexy. So what else can we do? Indeed, as 60% said, most of you will choose for a resection and an anoplasty, as described here by the group of Mark Levitt. They dissect at the mucocutaneous margin the mucosa or the full layer of the rectum over a few centimeters. Why do they dissect the full rectum? In order to create later on some slight tension and having a deep anus in the end. What are the results in this paper? They published on 32 cases. Unfortunately, the follow-up is not clear, and they described a recurrence of 10%. Also, the percentage of complications I could not find clearly in the paper, and we will all agree that it's important because it might be minor surgery, but the potential complications highlighted here can really have dramatic side effects and negative effect on quality of life of our patients. A recently published new technique, well, it's an old technique, but new for ERN patients, is the Delorme mucosectomy, published by De La Torre in the GPS in 2020, where they open just close to the mucocutaneous margin. They lift the prolapsed rectum with an mucosal cuff. The muscle is here. The muscle is fixed because it's not a full layer prolapse. Application of the muscle is done, and then the excess of mucosa is excised with a new anastomosis circumferentially. They described a group of 14 patients with a follow-up of 2.4 years, with, as you can see here, excellent results concerning recurrence and concerning complications. We did not find any follow-up data because the paper was just published 2 years ago. And again, we believe, Pernilla and I, that redo pull-through can be done, has been proposed by some authors, but is probably not outweighing the risks. It can be very major surgery for a problem of mucosal prolapse. One word on megarectum, which was also highlighted as a possible consequence of constipation by Pernilla before. You can see here an image of a megarectum. The etiology can be very different. It can be caused by hypomotility of the rectum. An underlying stenosis, of course, will increase a diameter increase of the rectum, and a disturbed rectal sensation will also lead to an increase of the diameter of the rectum. Moreover, if the diameter of the rectum then increases, the sensation is again decreased, and you come into a kind of a vicious circle. Excision of the megarectum has been described by different authors, as you can see here, with a manual anastomosis or with a mechanical anastomosis. However, it's important to keep some rectal reservoir because otherwise defecation habits might be worsened with incontinence as a consequence. Here you see in the inset an image of a circular stapler put transanally. But you need a good patient selection, patients without true incontinence, patients with good sphincters, with an intact spine and sacrum. But the risk for complications, ladies and gentlemen, should not be minimized because of the risk of pelvic nerve damage and ischemia after a previous pull-through, the complications can be large, and therefore some authors have suggested a tapering of a megarectum as an alternative, but we did not find any large data on this technical variant of megarectal surgical treatment.
Well, how about mislocated anus? Mislocation of anus is usually defined as when more than 50% of the anal opening is being located outside the sphincter complex. And the mislocation could, as you can see on the images, be either anterior, lateral, or posterior. And when a patient presents with symptoms and mislocation, and if bowel management did not lead to the wished effect, redo pull-through can be considered. But if the patient does not show symptoms, or if bowel management serves well, redo pull-through might not be the way to go, because redo surgery risks to harm nerves, muscles, and surrounding tissues. So again, selecting right patients to redo pull-through needs careful and multidisciplinary considerations. Next, please.
And indeed, Pernilla, this is why we would like to challenge you again by answering this question. This is a patient with an anteriorly misplaced anus, fecal incontinence in spite of adherence to bowel management. Would you go for redo pull-through? Would you go for an appendicostomy? Would you go for a combination of both? Or would you even be more aggressive and say that decompressive stoma is the way to go?
Okay, you can now vote for about half a minute. Thank you.
Exciting.
That's right.
Okay, I'll close the poll in a few seconds. You can quickly vote. So can you see the results now?
Yes, we can see them.
Okay, great.
I don't.
Wonderful. Oh, well, 97% it says they would do a redo pull-through, and 21% would do a redo plus appendicostomy, and the rest was 0%.
Okay.
So we will come back to appendicostomy, won't we, Mark?
Yes.
And now we would like to highlight a report from Wood, published in 2020. And this is about redo PSARP. They reported on patients with fecal incontinence, 682 patients, and all went through bowel management program. Then only 22% were selected to a redo PSARP, and the anal mislocation was the majority of the disorders among these patients. Next, please. So the outcome reported on 153 patients, they were divided in two different groups: good potential for continence and poor potential for continence. And this was with regard to sacral status and ARM type. So in those patients with good potential, that were about 50%, 55% became continent with laxatives, and 24% became clean with enemas. Among patients with poor potential for continence, with sacral malformations and severe type of ARM, 20% became continent with laxatives and 53% clean with enemas. And then you need to remember that this surgery was performed in a high volume expert center with very experienced surgeons. And we think that the results highlight that patients and doctors should have realistic expectations on redo surgery. Next, please. So continuing this report that is very honest, the Wood group also reported on complications in this redo PSARP group. And now 1/3 of patients experienced any complication, and that was in terms of stricture, prolapse. And 8% needed another redo PSARP, and 1/3 went through a stricture plasty. So once again, these results show that redo surgery is connected to complications, also among experienced surgeons. And we think that we should all have great respect for it and selecting our patients well. Next, please.
Indeed, and going back to the poll of the multiple choice question number 2, where 23% opted for a combined appendicostomy and a redo PSARP or a redo pull-through, I think this indeed is not wrong. On the contrary, we strongly believe that a bowel management program or a surgical bowel management program with an appendicostomy and a redo pull-through are not mutually exclusive. And again, this highlights what Pernilla just stressed, is such a decision, such a difficult decision on what is exactly the best choice. Should we combine? Should we one of both? Should we do both? This is really a difficult decision that should be taken by a multidisciplinary, experienced team before embarking on that. And this leads us to the last multiple choice question, Pernilla.
Yes. So, ladies and gentlemen, if you have a patient with anorectal malformation that you consider eligible for redo pull-through, what is then your choice? We or you operate on the child at your institution, or you refer the child to a national or international expert center, or you discuss the case in CPMS within ERN, and let the CPMS expert panel decide how and where to treat your patient. Or you discuss the case in another forum outside ERN.
Okay, you can now vote.
Just interesting to see how you consider reoperation.
And I do not happen to see the results, so please, if you could highlight them in a moment, Luz.
Yes, I will. I'll
Thanks.
close it in a few more seconds.
Yeah, it's an important question, and we're very much looking forward to the result.
Okay, so 44% would operate the child at their institution. 13% would refer it to a national or international expert center. 44% would discuss the case in CPMS, and 6% would discuss the case in a forum outside the ERN.
Thank you very much.
So indeed, this is very, very interesting, because at least 50% would discuss the case in a forum, whether it's CPMS or another one. And I think that's an important one. Still 44% would choose to operate a child at the own institution. And of course, we have no idea what the load is and what the experience of all these different institutions. Anyhow, I think it really highlights with this last multiple choice question what we would like you to take home as messages. And these are the next 4 things that based on our research for this lecture and our own experiences. And the number 1 is, of course, that, as Pernilla already highlighted, that patients, parents and surgeons should have realistic expectations, especially if the patient is in a bad prognosis group. And we try to give you some hints on how to determine exactly this bad prognosis group. What we also wanted to highlight is that an extensive workup is needed in patients that don't do well. And we refer again to the 10 different steps that we showed to you. But most importantly, ladies and gentlemen, is the last 2 messages that we want to bring to you. And that's the multidisciplinary discussion, which we strongly advise when a patient is considered for redo surgery. We don't talk about redo PSARP, we don't talk about redo pull-through, but we want to highlight the role of redo surgery as a whole for any of the 4 items that we proposed you during this webinar. Last but not least, a prospective high-quality registration and a centralization in any form whatsoever, as we heard before by Dr. Schmiedeke and Dalia Aminov in the previous webinar, of all those redo surgeries is very, very much needed. On behalf of Pernilla, I would like to thank you very much for your attention. We are available for any questions now or later on our email, as you can see on this slide. Thank you very much from my side.
Thank you very much.
Thank you both for this excellent presentation. Please, for the audience, ask your questions via the question field, then I will pass these on. In the meanwhile, I would like to thank you all for joining us, and of course, thank you, Marc and Pernilla. The webinar has been recorded and will be available on our GoToWebinar platform and on our YouTube channel. And I will be sending the links for this tomorrow. The links for the previous sessions are on our website, as are the details for the forthcoming webinars. And you can subscribe to our YouTube channel where you can easily find the past webinars. In the meanwhile, there have been some questions. It's our remarks about that it was a wonderful presentation. It's also very nice. And there was one, well, more of a statement of an adult who was born with ARM and would like to know how much experience the prospective surgeon has in this field. But she said that unfortunately some HCPs are reluctant to share their expertise in the numbers of patients. So that's not known for everyone.
No, but I agree, Lucy. It highlights the fact that we need objective data, high quality objective data. And of course, our Scandinavian friends and Pernilla in Sweden, they are so much forward in Europe on prospective high quality registries. I think this particular pathology of post-operative problems after ARM surgery, it's really a topic that should be further examined in such a way, and the data of these registers should be available, as I think is the case, Pernilla in Sweden, should be available to the public.
And I also have to add that I think that every radiology we perform, we need to save the images for later. I mean, to take them into concern later if the patient turns out to have problems. That is important to be objective.
Good point, indeed.
Well, further, there are no more questions, just a very many compliments for you two. So I will send these through to you. And if no one else has a question, I would like to thank you all and wish you a very good night. And Marc, you are right in time for the football this evening.
Indeed.
Perfect.
Please all support Belgium tonight. Thank you very much.
Okay.
Have a good evening.
Good evening.